Okay, I just want to mention this joking back and forth about standing up to get speakers' attentions. I once watched a moderator tell people, I will come up onto the stage and I will move a little bit closer to you, the closer you get to your deadline. And I watched her with one speaker and it was like a lion stalking a gazelle. The gazelle just was not seeing this at all, and the person kept coming closer. It was great theater. So, but that's why they give us 2 hours here, so we can run over a little bit. So Kavita, I don't know if we have all your joke slides here, but I know we have your real slides here. Kavita Patel is a fellow and managing director at the Engelberg Center for Healthcare Reform at the Brookings Institution, where she leads research on delivery system reforms, healthcare cost, physician payment, and healthcare workforce productivity. And I think she's going to touch on all of those. She's also a practicing primary care physician at Johns Hopkins, and she too brings a wealth of policy experience as the director of policy for the White House under President Obama, and as a senior advisor to Senator Ted Kennedy. So, Kavita, welcome.
All right. Thank you. All right, we're gonna try this out, and there's a big clock and the lion next to. I've never had anyone describe me as a gazelle, so I don't know if this would apply. And what Murray couldn't, what he had to leave out because of all my time in D.C. was that I was at UCLA and it ran for my years before. And I'm very happy to always happy to come back to Southern California, especially with the weather we've had in DC. So thank you to UCI, to Margaret Wong for making sure I actually got here, and to Murray for putting together a very fun panel of people that I like to call friends. So even though we look like we're in a bipartisan sandwich of sorts today, I'm not sure quite. I think that was probably intentional. It's a ham sandwich. I don't know. I don't eat pork, so and we're in Southern California. It's a paleo sandwich of some kind, probably. All right, so let's try. I'm going to try to kind of mix things up a little. And as Liz Fowler, you could not have a better person kind of give you kind of a motivation for why we needed the Affordable Care Act. So I'm not going to rehash any of that. I want to focus on kind of where we are now with a little bit of reflection at the end and kind of looking forward. And I think of it, I was also a Star Trek fan, and I think of those of you who will recognize the original Starship Enterprise on the left from I remember the old school Star Trek with William Shatner, and there's now many different versions, and then you'll see the revised version. We have some of the similar things playing out where some of you may think the implementation of health reform is more like the movie American Hustle. And in Washington, D.C., we think it's more like the House of Cards, which I think Joe and Liz have covered. So let's talk a little bit. All of us knew with the Affordable Care Act, for all its flaws, that there would be a health reform 2.0. And I think, and I'm not going to touch on, there's so many areas and aspects of kind of the 2.0 and what we need to do next. But as I think about those of you in the audience who are working in systems, in startup companies, in academic institutions, this is where I'd encourage you for the market outlook part of this to think about. And I'm going to touch on kind of physician payment, since that has a huge impact in the public sector and the private sector. I'm going to talk about what's happening in Medicaid. I'm not sure when those stories, some have been written, but while all this kind of arguing about Jim's CBO estimates and job killing and job growth have been going on, CMS has been approving billions of dollars in waivers that are trying to radically transform the Medicaid system, in large part built on California's Medicaid waivers. So I think that's an interesting aspect to look at. And then who the heck is going to do all of this? So I often find myself as a doctor being the person that people point the finger at. I'm ordering all the wrong tests, and I'm ordering the expensive drugs, and I'm in the pocket of companies and not looking out for patients' best interests. But when we look to solutions, we look to economists and lawyers. I think for the first time, we're starting to now say, well, we can't just look to, no offense to some of my economist and lawyer friends on the panel, but now we're starting to circle back and say, well, how do we get the doctors to actually change the way they work? And how can we get them to take on, financial risk? And again, in Southern California, I at UCLA and Rand, we were down the highway from HealthCare Partners. So we knew about models of care that were taking on risk, and up the street from Kaiser. So these things are not unfamiliar. However, it's going into this kind of health reform 2.0 concept. So let me just say something about the SGR. I think all of us unanimously will tell you that we do not think that the fix of all fixes is going to happen in the next couple of months, despite every email I get in my inbox, for those of you who are physicians, is the urge Congress to take action and repeal the SGR, and we have a fix, and we must fix it now. However, having said that, it's one of the first times that you've seen bipartisan, bicameral support, and I do think that that's a tone-setting description of how, from here on forward, conversations about changing fee-for-service are expected, no matter who's in the White House and no matter who has the majority in Congress. The bulk of what's been proposed has centered around these very mysterious APMs. It reminds me a lot of the mythical unicorn of the ACO as well. We didn't really know it until we had to build it. But the alternative payment models at a cost of approximately $150 billion is what's kind of proposed in this bicameral, bipartisan fix. And I have some of the details on here, so I'm not going to read through those. But you can see that a lot is left up to discretion, and there's a lot of flexibility. However, that can come at a price, as we've seen with some of the ACO implementation. All right, so let me get us to some of the, I'm going to breeze through some of this so that we can get to, if we even have time for Q&A. And now I want to talk a little bit about Medicaid, and there's a prevailing kind of opinion and then also estimates from the Congressional Budget Office and others that show that by year 2020, we talk about Medicare being the predominant payer on the public side and in the private side. Medicaid will outweigh that. No matter what happens in the next several years, because of expanded enrollment, Medicaid will kind of outshine and outweigh by numbers Medicare. And I think that's a scary proposition, because so much of what we've done in Medicare has been kind of constructed upon standards and programs which have been tested and tried and evaluated to death in some cases. In Medicaid, because of what I've just described to you with this dynamic of states proposing waivers to do their own thing, the federal government coming in and saying, we'll give you the billions of dollars to do those waivers, we're seeing a very kind of quilt-like effect across the nation. Let me highlight Oregon, because it's received a lot of attention. I said a lot of these reforms are modeled after California. I'm not going to talk to Californians about California Medicaid or Medi-Cal, but I will tell you about Oregon and how there's a big bet going on about where we can really bend the cost curve within Medicaid. And just so that you can see that the agreement that they struck with the federal government was for projected state and federal Medicaid spending for $11 billion. This was with a waivers agreement. And in return, Oregon said that they would bend the cost curve by 2% over the next 2 years or face stiff penalties. So 2% is a lot of money, and given the percentage that they promised over the time period, is a real just a real test. And we've seen a lot of, those of you who are in academics, you've seen a lot of the publications. Kate Baker and some colleagues have published around Oregon's Medicaid enrollment processes. Those predate this 2% waiver. However, the findings of those studies do have implications. The baseline year is the 2011 fiscal year Oregon spend. The trend was 5.4% as calculated by OMB for the president's budget. So the state has to achieve 4.4% by the end of year 2 and 3.4%, the 2% reduction thereafter. So no reductions to benefits and eligibility can be accomplished in order to meet those financial targets. So it's really structured on a strong delivery system reform and a lot of financials and sticks out at the at what I'm going to call the CCO, and sometimes I get stuck in what the heck these acronyms represent. So it's the Coordinated Care Organization. Notice they didn't want to call it the Accountable Care Organization, but it's all the same thing. And really the CCO, there are, as of about 2 to 3 months ago, about 16 CCOs, which are local networks basically, ACOs, and kind of the conversation we would have broadly. And care is coordinated at every single point and across transitions, across site of service, so including post-acute. Those of you who know that a large share of Medicaid spending can be driven in, the non-ambulatory setting, that this is where CCOs kind of take a lot of ownership over having the dollars, the dollars follow the person, and now the state is kind of following both, and it's really interesting, as I mentioned. Those of you who haven't had a chance to look at Kate Baker's New England Journal article in 2013, I'd highly recommend it, because she talks about the 2008 Medicaid experience, and the bottom line, Medicaid coverage generated no significant improvements in measured physical health outcomes in the first 2 years. but it did increase use of healthcare services, raise rates of diabetes detection and management, lower rates of depression, and reduce financial strain. It's more complicated than that, so what is financial strain? But a lot of criticism was pointed at some of these findings in thinking about how we're talking up through Medicaid system reforms and what Medicaid enrollment what even just expanded access to Medicaid will do in terms of driving cost and utilization, and is it resulting in better outcomes? And that's really a boil down of the controversy. So let me get to healthcare. Let me get to the next phase of health reform. So here's where I still practice, as Marie mentioned, and everybody's been asking this question. If you talk to the AAMC, they'll tell you we have a shortage of about 50,000 doctors. If you look, there was a study in Health Affairs that said, you know, we actually might have too many in certain areas, and certainly if we change some of our scope of practice laws, we might have just enough, depending on what just enough is. I come from the great state of Texas, where we take immense pride in stopping anybody from taking any of our territory as physicians, and that includes nurse practitioners, PAs, and doctors from other states for that matter. So I know that the dynamic in many states, it's really boiled down to these kind of scope of practice laws and these gilded enterprises that really hold on tight to what we've been doing as healthcare professionals. But I have to tell you, we can talk about it. We all come from Washington, D.C., and we can talk about what the feds should do, and we should talk about national policy for our workforce. What's utterly fascinating to me is that when you go into ACOs, private market ACOs, or some of these even Medicaid CCOs like Oregon is doing, they aren't waiting for regulatory changes or laws. They're reconfiguring the workforce in very creative ways using existing scope of practice laws and talking about things like retraining the woman that answers the phone in our office to do a better job of engaging patients around complex chronic diseases. So it's interesting to me that one of the largest drivers of job growth in the nation, that is healthcare, usually through low-wage workers, not overpaid people like myself, is something that we're now taking seriously and mapping that to these delivery system reforms that Liz talked about. So I do find it to be a very important conversation, and in terms of healthcare outlooks and trends, we can start to expect that companies, third-party vendors, because of concerns about Stark laws, third-party vendors who can come and do this kind of hands-on tactical reconstruction of workflows and education and training might be the ACOs and large clinically integrated systems' best friend. We've already seen Optum come in and do this in Tucson. We've seen other services try to come in and do this, and I think that's only going to grow. There was a New York Times article, I think Elizabeth Rosenthal wrote this, around doctors shifting more of, doctors shift to jobs with salaries. It's also no surprise that when you talk to a physician coming out of medical school or residency, that they are more than happy to take a salaried job with kind of guaranteed hours and guaranteed wages in an effort to not have what I grew up with, which was the notion that you could hang a shingle and you could make millions of dollars and buy many homes across many states if you practice robustly and with high productivity in a fee-for-service system. So the impact and trend of growing women in the physician workforce and a growing desire to have salary jobs, as well as explosive growth in primary care for part-time work. Most women, as well as many men, are choosing part-time jobs. All of this has kind of an important effect. And I didn't know Peter Bierhaus would be in the audience, and got to see him earlier this morning. I give Peter all the credit for teaching me what I did not know about nursing supply. And so let me just go to Peter, kind of just all you need to do is see the dips and highs with our the FTEs of nurses that were aged 23 to 25 from 1973 to 2010, and you can see, oops, sorry, didn't mean to go back. I wanted to try to point. What you can see with the dips and valleys is that we've had conversations mostly in the 90s around everybody talking about nursing shortages. I was in California when we started the mandated ratios for nursing care, and so now we've seen an uptick in some of this. And you may ask the question, well, why is that? And Peter was one of the kind of people who put this together very elegantly in some health affairs papers and a New England Journal paper around how there was just this multi-pronged support from nonprofits, outside foundations, private sector, and then some of the states taking the initiative around some coordinated workforce centers. I think that Peter's findings in the nursing space really have kind of the same, I would say they're a preview of what I think is happening in the NPPA and more importantly the MD space, where so much of the money gets concentrated, even though the large proportion of our costs, remember, are in hospitals. So big initiatives can work, but without estimates of demand on workforce, we can't really estimate the size of some of the longer-term shortage issues. And the workforce piece is, I think, something that tends to get siloed in conversations with only other workforce people or academics. Unfortunately, I think that because of all these dynamics that are happening, an educated workforce is going to be your best friend throughout all of these projections or any of these hypotheses about system reform. So Liz touched on this, so I'm going to go through this, but I think it's important to point out that the Affordable Care Act, we talk about exchanges and the New York Times headlines, and God bless McKinsey, because they always seem to come out with a report so well-timed to refute everything that anybody else is thinking, and we're always scrambling to kind of understand, well, who's right, and is CBO wrong, and what did McKinsey say about it? But I think at the end of the day, the ACA was actually important to remember. There were so many other achievements that don't get scored, or not CBO scored, but don't get highlighted and scored and emphasized, and I think they deserve their day. And some of them don't work. The Class Act is a good example of something that very clearly the administration said, you know what, we're not going to be able to implement and execute this, and we're just not going to be able to do what we needed to do for long-term care. However, that is an important area. But biosimilars, Indian healthcare, physician payment sunshine, Medicaid for low income, elder justice, there were so many things that were kind of baked in there that I think get overlooked. And Liz has talked about this. I firmly believe, just like we've had with Medicare, many versions of kind of Reform 2.0. And I like to say that this was, I worked for Ted Kennedy, and he liked to always remind us that, I firmly believe that healthcare was a right. We can argue about who and how and when and who should pay for it, but those of us who work in the system have largely also felt like it was a movement for health justice, and that doesn't also get spoken enough. And I do think that it's important to see how we can have an effect on so many of the conversations on civil rights, women's rights, gay and lesbian rights, just even the conversation around birth control and access to preventive services for women has sparked, I think, so many other important dialogues. So that's one thing that I want to emphasize. Coverage and affordability will be a key test. I did want to make the point, I do a lot of work with systems and providers, and many integrated systems are also looking at getting their own book of business, whether it's in Medicare Advantage or their own plan on the exchange. Those of you who know North Shore Long Island Jewish, one of the largest systems in the New York area, one of the most successful ones, their CEO, Michael Dowling, at a conference a couple of weeks ago actually said that, and they have a plan on the New York State Exchange, which is one of the ones that's going well, supposedly. And so Michael Dowling actually made the comment that their enrollment was as expected. They got one patient with a diagnosis of MS, and that might cripple the cost for their health exchange plan. And of course, there's the corridors and the 3 Rs that Joe mentioned, but do not make assumptions that everyone's going to just go wholeheartedly and see having their own plan as a really reasonable option. But look for growth in Medicare Advantage. Now, growing a new plan in Medicare Advantage, because you have to come in as a 3-star rated plan, may not be optimal, but you're seeing a lot of systems like Meridian Health in New Jersey who joined up with Geisinger, who had a 4.5-star rating MA plan to add into the New Jersey market. So look for things like that to really understand coverage and then this concept of affordability. And then finally, ACA may be a landmark, as I mentioned, for racial and ethnic minorities. And so I do want to just say that there is the potential. When I was a health services researcher at UCLA, I would always say, like, God, we do a lot of disparities research. There's an awful lot of healthcare disparities. And I remember thinking, are we ever going to find solutions to, we would do research that showed us how many disparities there were and all the problems. And I often got disparity fatigue as a research, like, well, this is horrible. What are we going to do about it? So I do think that the ACA, very importantly, will actually be one of those solutions. expansions. And certainly we've seen some evidence of that in the state of Massachusetts with their expansion. And in my own state of Texas, we've also started seeing changes despite their lack of a Medicaid enrollment. We've seen examples in states where they've had expansion of some kind or access to insurance of some kind, some elimination of those disparities. So here's just some highlights and some points about what the Affordable Care Act is and was. You know, it is and was about self-interest and about the public interest. And some would say that it was definitely very expensive. The president put $1 trillion price tag, as Liz would affectionately remember. There were those of us who were keeping like flip chart Post-its of when we were adding things in and it would be a coster. And we were like, oh, we're at 987. We got to find something that'll pluck it off. Can we take one good idea that'll save us some money and put it on the board? And so, but then there's some that would say it wasn't enough. It didn't go far enough to get us to where we needed to be, and that was a critical flaw. And some would argue that it was seriously bipartisan because of how party votes came around, and that it was actually excessively partisan in ways that those of us who worked across party lines in general often found that there were many Republican colleagues who agreed with so many aspects of it, but that they just couldn't take the vote for party reasons. And I will say that just having Ted Kennedy pass away, having had him have worked to pass a state law when John Kerry was running for president to find a way to have a special election so that the governor cannot appoint someone, and then having that bite him literally when he passed away and we had to go to a special election in Massachusetts where Martha Coakley somehow handed over the Senate seat to an unknown to the country, Scott Brown. We really fully will never appreciate, but I think those of us who are working near and on the Hill will completely tell you that changed everything, because we couldn't go to conference, we couldn't do the kinds of things that we normally do to work out these bills. So it's been 4 years, but it really burned a lot of us 5 years ago when some of these things happened. So I'll close by kind of quoting F. Scott. I either go with an F. Scott Fitzgerald, or actually I usually go with Yogi Berra because he's so often my favorite in all of life, but I wanted to be a little more highfalutin since Murray is a highfalutin kind of guy. So I want to close with an F. Scott Fitzgerald quote. And then have a closing graphic, since Joe and Dean and Liz inspired me. The test of a first-rate intelligence is the ability to hold two opposed ideas in mind at the same time and still retain the ability to function. And many of us would argue that the Affordable Care Act definitely tried to do that. So in closing, I think the president has been doing a lot. You know, when the president had a press conference with the HealthCare.gov debacles, Liz and I have never talked about it, but it sure as heck was, when the president stands at the podium for over an hour, taking those questions and defending, and you could see clearly getting very frustrated. Oh, you can bet that reverberated across the Oval Office and across all the executive branches and buildings. But this is a president that's trying to own the mistakes, as many as we've had. So I won't say, Liz made some of the analogies already between Part D and Medicare implementation, but happy to, I don't know if we'll have time for questions, so please feel free to email me, and thank you for your time.